doesn't show any response to the suctioning of the airway, Goodell's airway, oxygen mask, NRM mask, and bag and wall mask. Then we go for the definitive airway. So, what are the indication for a definitive airway? Number A, inability to maintain a patient airway by other means with impending or potential airway compromise, such as following inhalational injuries such as burn injury, facial fractures, or retropharyngeal hematoma, or inability to maintain adequate oxygenation by face mask oxygen supplementation or presence of apnea, or other such as combativeness resulting from cerebral hyperperfusion, or the patient is having low GCS score of 8 or less. So we go for the definitive airway. So what are the different methods for definitive airway? We have non-surgical. The non-surgical consists of tracheal intubation. So, in tracheal intubation, we simply place a flexible plastic tube into the trachea to maintain the airway. Procedures such as we do under the direct laryngoscopy, video laryngoscopy, and digital intubation, etc. For this, first we need to pre-oxygenate the patient with bag wall mask, and then we sedate the patient. So then we pass the endotracheal through direct laryngoscopy. That's how we perform the direct laryngoscopy. We take a laryngoscope with the light source, and then we pass the endotracheal tube. Then comes the surgical. There are two methods. One is emergency, that is cricothyroidotomy, also known as cricothyroidotomy, an important emergency procedure that we do. If the patient is having facial trauma, facial injuries, or we can't perform the endotracheal intubation, so we go for the cricothyroidotomy. The second is the tracheostomy. This is an operative procedure, and we this is mostly done by the ENT surgeons. And they make an incision over the first and second tracheal ring and make a permanent tracheostomy pathway and place a tracheostomy tube. The B comes from breathing and ventilation. Breathing and ventilation, we expose the chest if it's moving or not. We look for the tracheal deviation, accessory muscle use retraction, or absence of spontaneous breath, or we look for any paradoxical chest wall movement. We auscultate the chest for gas exchange if bilaterally the air entry is normal, or we can hear the sounds or not. So what we have to identify in breathing, we have to identify the massive hemothorax, flail chest, ref fracture, or open pneumothorax, or pulmonary contusion or tension pneumothorax. What is tension pneumothorax? Air trapping in the pleural space between the lung and chest wall, and it can be life threatening if it occurs. So what we do on physical exam, we hear no breath sound on that side of the chest where there is tension pneumothorax, or patient is having air hunger, distending neck veins, or tracheal shift. Treatment, what we do first, we in emergency we do needle decompression. In the second intercostal space, clavicle line